Hello, everyone. Welcome in. I'm Andrew Donlin, editor of Home Healthcare News. It's my pleasure to be moderating today's webinar, Analyzing the PIPR Report with SimiTree. Thank you to SimiTree for bringing us today's webinar. Before I introduce our speaker, I'd like to go over a few housekeeping items. Number one, your audio has been disabled for sound quality. Number two, we do welcome that the audience ask questions at any time. You can do that through the Q&A box on Zoom, and we will try to get to as many of those questions as we can toward the end. And thirdly, this webinar is being recorded. If you miss anything, the recording will be shared with you via email. Now I'm excited to introduce our speaker today. We are joined by Claudia Baker, Senior Manager at SimiTree. Claudia, thank you for being here today, and I'll pass the mic off to you before I come back for Q&A at the end of the call. Thanks, Claudia.
All right, thanks, Andrew. And welcome, everybody. So I just want to start off by saying that I'm a nurse and I've been in this industry for a really long time, and I am excited to be speaking to you, everyone, today. Even though this is on a brand new topic, right? I mean, these are topics that we're all learning together as we go, which is how they usually do this for us from CMS. So I refer to this PIPR report as a PIPR report. It's commonly as our acronym for it. So I will start off by sharing with you Piper, which is my dog, Piper. So a lot of times when I'm talking in the background, we all work from home or from different settings. And when I am referring to these Piper reports, she actually gets up and comes over to visit me to see what in the world Mama wants. So I will share that with you to begin with, kind of as a little bit of an icebreaker. And I would love to talk to you about her for the next hour because she's just a fantastic dog. But what we're actually going to talk about today are these goals here. So we do need to understand this pre-implementation performance report, or the PIPR, because we need to use it to establish targets for improvement. We need to look at the PIPR trends and see in comparison to the other two reports we've gotten. So look at all three reports, look at those trends. And then we will finish up today by looking at a lot of actions that you can take by clinicians, clinical managers in the agencies, your quality team members, everybody in the entire agency and the entire companies are out there to help improve the delivery of care and all these metrics under our home health value-based purchasing. So for starters, let's figure out where you get these reports from. If you have not looked at yours, you need to go into the key system and have it, or have your billing folks or whoever, however you can get to these, and have it pulled. And so you can look at these, because we now have ones that came out back in November, and then in January and April of 23 that cover different timeframes for us here. So the most recent ones came out in April of 23, which was just last month, seems further back now. But that's what we're looking at. And this is what they look like. Okay, so you will get a report that looks like this, and you will need to keep in mind that we're looking at OASIS-based measures, right? Discharge to community, improvement in dyspnea, that improvement in management of oral meds. And then we've got two total normalized composite scores, or TNC scores, for the functional areas in mobility and in self-care. Under claims-based measures, we have acute care hospitalizations and then emergency department use without being hospitalized. So those are the two claims-based measures that that come out of, or that they're looking at for value-based purchasing. And then we have the survey-based measures. So these come out of our home health CAHPS surveys. And these include the overall care of our patients, what we're doing for them, what their perception is of what we're doing for them, and that's very different. Communication between providers and patients, how well are we communicating, not just about their care, but about a number of things as well, and we'll go through that towards the end of the presentation. Specific care issues, pain, medications, et cetera. Their overall rating of your agency and their willingness to recommend your agency to others. So we've got those survey-based measures, claims-based measures, and OASIS-based measures that are all being reported in this measure performance summary. Now, this first column that we're looking at on this PIPR report is what performance year we're looking at, because it is different. Whether or not we're looking at the OASIS-based measures, those tend to be a little bit more up to date by a quarter. So those right now, what we're looking at, the ones we got in April, are up through the end of the year in 2022. And then the claims-based and the survey-based measures go back to the end of September, is where that rolling year, if you will, ends. I would say that one of the most important columns on this performance summary report for you is your agency's ranking. Where do you fall, right? Because this is the information that you want to try to get out of this. Where do you stand in value-based purchasing right now? What measures, what areas, what focus do you or your agency need to really, what direction do you need to head in to either improve these or just to see where you stand, right? Maybe you're doing very, very well at some of these. Then how do you maintain that? Because if you already are in that top decile or that top 10% of agencies, then good for you, absolutely. So how do you stay there, right? So it's still, nothing's ever just a given, like you reach it one time and then you're done. We're going to need to continue to work on these year after year, because the whole point here is that performance improvement, making sure that we are meeting all of the quality outcomes that we need to meet in taking care of our patients and being able to prove it, of course, right? So we are looking at then the measures. You're going to look at your agency's measures, which is the second column, against where you land in either the 25th percentile, meaning you're in the lowest quarter of the measure, the 50th percentile, meaning you have hit at least that achievement of being in at least at or better than half of the group that's in your cohort, and the 75th percentile, meaning that you're better than at least halfway there, but not quite into that top 10%. And the mean of the top decile meaning 10, meaning that you're in the top 10% or the 90th percentile there. Okay, so as I alluded to, the 50th percentile is your preliminary achievement threshold, because we look at whether or not you are getting to the benchmark of the 90th percent, or whether or not you have achieved at least the 50th percentile in order to go forward. So when you're looking at that information, that 50th, that achievement threshold, anything below that means that your scores are going to start to negatively impact the amount of money that you might get out of value-based purchasing when it comes down to the final payment days, when they're deciding whether or not you get a bump in reimbursement of 5% or you get some financial impact, negatively, depends on whether or not you're above or below that achievement threshold. And that is also the point where you will be trying to get to that point with your outcomes and show improvement to the point of getting to those levels, right? So that's what those columns mean for you. So again, your agency's performance, that second column, that's your scores compared to the 25th, 50th, 75%, or top 10% columns that I just showed you. Is crucial that you know where you stand, right? Because you need to know where you're at right now, what you need to work on. And it could be, again, that maybe you're doing really well in some areas, but not as well in others. So if you'll look at that next column that I highlighted before, the one that says where your agency falls in the percentile ranking within your cohort, you see that you've got some ranges there. So it says in the discharge to community, this particular agency is in the 25 to 49% ranking, all the way down to the only one that they are doing okay in OASIS-based measures is the TNC for self-care, where they have achieved that 50th percentile. You're in the 50 to 74th percentile ranking. So in this case, in looking at it, your OASIS, all of your OASIS measures, really, except for the self-care ones, are ones that you should be focusing on, right? You should be figuring out a way to improve those, to do more accurate OASIS scoring, maybe OASIS education, lots of things. And again, we'll go through some actions and some things that you can take to hopefully get better at doing those things. So under the claims-based measures that we're looking at here, we've got acute care hospitalizations, and the 18.146 number that your agency performed, and this isn't anybody's agency, obviously, these are just example numbers that we have for you here, but that 18.146 is less than 25% of where they need to be. Meaning in this case, whereas in the OASIS measures, the higher the better, obviously in acute care hospitalization, we want to try to keep people out. So in this case, the 18% percentile is way higher than anything that we have on here. The top 10 percentile is an agency in the far right column that may score, or in your group, 7.749 around that or less, right, to be in that top 10th percentile. So in this case, that is an area, a claims-based area of rehospitalizations, acute care hospitalizations, that this agency would very much need to be focusing on. And again, I'm a nurse, so I mean, I think we can all agree, and we have for a long time been trying really hard to keep people out of the hospital. Now we've got, clear financial reason for keeping them out of the hospital as well. So just take note that those numbers in both the survey measures and the OASIS-based measures, the higher the better. But in the claims-based measures, you're looking for a lower score because we don't want people to have those kind of events. So the same thing with the emergency department without use. This agency scored at a 10.34. They fell in that rank, in that measure, at 50 to 74, which put them in the 50th percentile there. Okay, so I hope all of that makes sense. So that's how you read these PIPR reports. I was going to say PIPR reports, but that's a whole nother thing to look at. Under the survey-based measures, again, we're hopefully scoring higher in all of these measures. In this example, we're looking at a mixed bag here. When you look at the third column, that's looking at your agency's percentile rankings within your cohort. We've got some here that are falling between 50 and 74, some that are falling between 25 to 49. So if I were looking at these as a leader in the agency, I would focus in these areas on that communication between providers and patients, and I would focus more on that overall rating. What is it maybe that's keeping these patients' perception of our agency as being negative a bit in that, or are they just not, happy? And communication is one of those kind of tricky ones, whereas we as clinicians sometimes, or even as anybody in the agency who's communicating with the patient from intake all the way through to billing, everybody has a role in it, scheduling, clinical managers, not just the clinicians in the field. What we may think we're doing good communication or doing it very well with somebody. We're, telling them about their meds. We're telling them about everything that we feel like they should know about heart failure or how to do their home exercise program or whatever it is we're teaching them about. Patients' perception of that may be that communication is that, you just didn't call before you came, or I had no idea an agency was even showing up, right? So somebody from the agency didn't call me and let me know that my doctor had even ordered home health. All of those things matter, and those are the things that are very important to patients. And I've been saying this for over 30 years in this business, that we are guests in the patient's home, right? So we need to make sure that we are being considerate of their time. And, you know, there's a number of those kinds of best practice strategies that we can use, and we'll talk about them more as we go. But the point here is that you look at this PIPR report, you study it, you make sure that you are capturing the things or looking at the things that you really need to focus on at your agency, and then come up with a performance improvement plan. Get to the root of why it might not be as high as you want it to be, or you think it might be, or we're expecting, and then go from there. We'll take some actions on it, and you will definitely need to take action quickly, because we are already really in June, basically later this week. So we're already well into this year, where this is the year that they're taking information from, right? Where they're taking our data, they're looking at what we're doing, and it will be compared to future, what we do next year, the first real performance year. And then from there, measure whether or not we've improved or not, or where we're going, or where we are at when it comes to the actual payment and payout under value-based purchasing, which will be in 2025. So while it feels like it's down the road, right, before we actually get hit, or whether we get a bonus or whether we get hit or dinged on it, is fair enough, a little bit further down the road, but we're being measured on it now. So we can't, we need to take every opportunity that we can, use this information, study it, make sure we understand what it means, and then go from there. Okay, so we have laid this out for you in a little bit of a different look here. So for the claims-based measures, you will see along the bottom, we've got an axis on the left side. We've got some dates across the bottom that tell you that these were the highs and the lows of the claims-based measures, from the top percentile down to the least, for acute care hospitalization, both in November of 22, January of 23, and then April of 23, and then compared. So what this says is that in that time period where they've been sending us information, what the thresholds are, the high and the low points that we are being measured in, really hadn't changed all that much. So these have only varied slightly, both the claims-based measures in these. Remember, the lower the number, the better. So really the target that you're trying to hit, the 7.75, 72, or 7.73, really haven't changed. It's not varying all that much. So we can really take this information and not worry that it's going to probably immensely change from what we will see next year and going forward. So again, valid information, valid data that they're giving us back, valid information to be able to use in looking at your agency against these numbers. Same thing with emergency department use. We've got this laid out for you here in April 23, January 23, and then back from November. And the low threshold from 4.68, 4.63, and 4.67 really hasn't changed all that much. So these are numbers that you can take to the bank. Pardon the pun up for you there, as to what we're looking at, what they're expecting us to do, and what those high and low numbers are. So we laid each of these out for you, and I'm not going to go through every one of these slides, but what we did for you here is look at OASIS-based measures in the same way, which with each one of the measures on this slide. We've got the discharge to community, we've got the dyspnea, we've got oral meds, and both the bottom and the high thresholds. And in OASIS-based measures, the higher the better. So the number at the top is what we're all shooting for. That only the top 10% would be at that highest best number. But there's not a whole lot of range there between the two best and, for lack of better words, worst scoring that you could have in there. So you can use these as your own reference. I'm not going to go through each one of them. Now, the OASIS-based normalized composite scores for mobility and for self-care look a little different because they are calculated measures based on multiple outcome measures. So under mobility, we've got several that they score in together, and they're coming up with a number of points that you get based on how much the patient showed improvement, right? So if you're doing ambulation, improvement in ambulation, they're really going to be looking at how far you move the needle with how well or how much better we got that person ambulating. So if they ranked on the OASIS scoring from a 1 to 2, or I'm sorry, from a 2 to a 1, let's do it in the positive, from a 2 down to a 1, then that is like 1 point that you get to factor into that total normalized composite score. And it takes several of the mobility measures and then several of the self-care measures and adds them up, and then you see what you get. So it's a much shorter, a little bit harder to move that needle because we're only looking at, in most of the OASIS answers for these areas, for anywhere from 4 to 6 points that it could move in either direction. So again, the more you move that needle, the more that you show improvement, demonstrate improvement for your patients, the better the score will be at the top as well. So keep in mind when you're looking at these, or if you're using these as a guide to go by, to look at your scores against where you fall in here, keep that in mind. So one thing to note in here is that both of these scores in OASIS from November through to April really have improved, at least marginally, right? So the higher number there for the mobility TNC score goes from a 0.987 up to now a 1.011. So we are seeing people continuously trying to improve, get our patients better. Could be more OASIS accuracy scoring, that type of thing that's actually proven out or showing that the patients really are improving. So little bit of movement that we're seeing in each one of these towards the positive, towards better outcome measures, which is what CMS saw in the 9 pilot states that did this for the 5 years that led up to everybody else doing these scores, is that they really did see a lot of improvement in the outcomes for the patients. That's the reason it rolled out to everybody else. All right, in the survey-based measures, again, they're not moving, but so much. Part of this is that the gaps are a lot more narrow here, because in the OASIS-based scoring, you've got about 2 to 5% of points of a swing that you could do there. And that's a lot bigger than in a survey-based measure where you really, the points change might be closer to like a 0.1 or a 0.2 points change that you're going to see. It takes a lot more patients responding, a lot more. If you only have a scale of 1 to 5 that they're scoring on, then it takes a lot more effort to get those to move. And some would argue that we only have so much control in the patient's perception of what we do. So it does make it a little bit harder as well. But we're going to go through some things that I think will help you there. Okay, so we have a few more of these things. We also included in here for you the achievement score calculations and another one that's got some math on it as well. I think to me, the takeaway from this is that out of the claims-based measures, 35% of this whole achievement score calculation comes from claims-based, 35% comes from OASIS-based, 30% comes from the CAHPS surveys. But in the claims-based measures, acute care hospitalization accounts for 75% of that 35% that's total, that's factoring into our total performance scores. So with that, that means that acute care hospitalization is 26.25% of the whole score. So to say that there's a lot of emphasis on acute care hospitalization is an understatement. So if you're not looking at any of them, and unless you're really, really good at this, I would say that is definitely one of the measures that you would want to focus on. And just the fact that we want to keep people out of the hospital. That makes perfect sense, right? As to why there's so much focus on that one. So I'm not going to go into any of the math here for you. Luckily, a lot of EMRs are measuring these things for you and have taken the PIPR reports, calculated it into the scores scoring. If you have an outside vendor that helps you calculate these as well. So they may very well be giving you lots of really good reports and things to focus on and to measure as well. So they would be giving you these scores, but this is where they come from. Okay, your care points. I'm sorry, hang on just a second for me. Your care points are, next. There we go. The care points are actually the higher of the achievement points or the improvement points for each measure that's reported in the interim performance report and that annual performance report that you will get. So again, if you don't hit that 50% threshold, that achievement level to get those achievement points going forward, they will look at your improvement scores to see whether or not you have, even if you started in that 25 to 49% or below 25% in a particular category, then your thing now, right, is improvement. So you need to be putting in measures to try to improve. So they will take the higher of the achievement points that you had or the improvement points for each measure. Okay. So also in these reports, when you get them, in the two columns that are highlighted for you to the right, you'll see where you get how you get achievement points and how it would add into the total performance score. And again, I'm not going to add all these up or speak to it extensively, again, because I would hope that your third-party software or your EMRs are helping you come up with these scores. But in this case, you can see that if you don't hit at least that 50 percentile, you don't get really any, see the zeros in the achievement points, you don't get any towards the total performance scores, at least initially. In this case, where this agency scored well in the TNC score for self-care, then that adds some achievement points and then factors into the TPS score as well. Likewise, in the claims-based measures here, they did not meet the threshold, the achievement threshold for acute care hospitalizations, but they did for the emergency department use piece. And that's where you're getting points or not getting points, and then it adds up there for you. Okay, so where do you begin? How do you get better at this, right? Begin with this data. It's the whole point of our conversation today, other than looking at a picture of my dog. Today, if you haven't already, you've got to pull these PIPR reports, look at what your lowest performance measures are, compare it against the national averages and those percentile rankings, because that is what it is. We're looking at it against the whole national ranking. And you are in a cohort, a larger or a smaller cohort, depending on the size of your agency. Most people fall in the larger size, but they are comparing, trying to compare apples to apples with that respect. So review those home health value-based purchasing items over the past 12 months. Focus on any negative trends that you have going on over the past 3 to 6 months, and then look forward, right? How do we establish some targets for the next 3, 6, and 12 months? Could it be, again, I would say that most people do hospitalization, keeping people out of acute care hospitals, and then whatever else your agency needs to focus on. What are you not doing well? What would give you the biggest bang for your buck, right? The most in an improvement score for you. Maybe you're just on the cusp of being at the threshold for it, then focus on that one, right? That you would want to take that and move it just that extra little notch to get over the hump into where you need to be. Utilize any dashboards. Do set those targets. Make sure that you are very, that if you're like me, as we get older, days and weeks and months go by and you don't want that to happen. So make sure that you're setting yourself some clear targets, putting it in a performance improvement measure that you're looking at, that you're studying, that you're keeping in front of your face, keeping in front of your staff's face, and that everyone's aware of it, so that, because it takes everybody at the agency to make these changes. But establish those targets maybe for the next 3, 6, and 12 months going out. And to do that, utilize some dashboards with your current scores and goals. Again, make sure that all of your staff are included in that. Beginning with that data, look at hospitalization trends. Is that your staff's go-to move instead of going out and doing a call after hours, is to just send the person to the hospital? I've seen it happen a lot, right? And you may not think it happens for you, but if your data comes back and proves that differently, just accept it, learn from it, move on, right? That's the whole point here. This was the whole point behind all of this, was that we would improve, that we would get better at a lot of these things. So you won't know what you need to do until you identify any trends that you might need to focus on there. Know what your common OASIS responses are for the ones that factor into this. What's your staff saying about these? How are they answering these OASIS pieces? Are they even answering them accurately? And I say that a fair amount over and over, because we think we're doing okay with it. But I have taught OASIS for years, and I can tell you that what we as clinicians think of as the right answer to a lot of those OASIS items are not really what CMS expects us to answer there, or we're allowed to answer there, right? So make sure that you're answering all of those things accurately. So know what those common OASIS responses are. Look at your survey responses, and not, all those CAHPS surveys that we get back, and not just the stats, but look at the comments as well, because sometimes you will glean more out of the comments than you do sometimes out of the overall, because somebody may give you a 4 out of 5 on something and you think, okay, yay for me, that's fine. But what you really get out of it is that they either really, really liked a particular clinician, or that they gave us a 4 because they don't want to ruffle feathers, and then they go into some issues that they have found with a particular clinician. It was all good except for that therapist who didn't, who never called me. It would have been a 5 if I had gotten more phone calls, or knew that people were coming, or if they showed up when they were supposed to, et cetera, et cetera. So sometimes those kind of things are in the comments. And if you don't look at those comments, you're not going to get really all of the information that you can out of a survey. All right, so acting on that data, develop those written and specific plans to improve those outcomes. Incorporate it into your overall QAPI programs. make sure that everybody knows it, make sure you've got assigned responsibilities and timeframes for follow-up tasks, and that you stick with it. This is not an overnight fix. This is a change in the way that you do business if you're not already performing at this level. I would equate it to the same way if somebody goes on a diet. You can go on a diet for a few weeks and you might make minimal change. But if you change the way you eat and you change the way you exercise and you really look at your overall lifestyle, then you are changing your diet for the long haul, right? And you'll be healthier for a lot longer time. It's the same way with this. You can't do just a quick PI plan and in 3 or 6 months say, all right, we did what we were supposed to do and give up on it. You really have to continue to do those follow-up tasks, stay on it. Prioritize the measures that you want to focus on, whichever ones may have the greatest impact to you. And again, that hospitalization accounts for 26.25% of that total performance score. And grooming alone makes up 1.46% of that. So grooming is a question that in the past, because it didn't factor into PDGM payment and that sort of thing, that we didn't focus on as much when we did a lot of our training. Well, if grooming is this important, make sure everybody knows how to answer that grooming question, right? It's very important. Reevaluate those, all of your processes, right? So OASIS review, how do you do that OASIS review at your agency? Who's doing your OASIS review? Do the people who are doing the OASIS review know what they're doing, right? Because I have found many agencies who really think they're doing the best that they can for it. And then you learn that maybe the person doing the OASIS review didn't stay up on all the education and a lot of coding that factors into OASIS, and everything else changes every year. People need to know that, stay up on it. We just switched over to OASIS-E, right? Lots of things to know and learn. It was the biggest change we've had in OASIS since 2000 when it came out. So make sure that whoever's doing all of that knows what they're doing in your review. And you might want to look at outsourcing the review of that piece if you don't have those internal strengths, even if it's temporary, right? At least enough to make sure that you are doing what needs to be done, catching the things that need to be captured. Interdisciplinary collaboration, people talking to each other, is huge. And it sounds like it shouldn't be that big of a task, but it really is. Everybody goes out and does their own thing. So talking to each other about what's going on with the patient, factoring that into our OASIS scores if we need to. We also need to look at our customer service practices. So what does the patient follow-up look like? How are phone calls routed? If somebody calls into the office to ask, where is my nurse or where's my therapist? How does that work? Is it an automated system and they get frustrated and they don't want to call back? That's one form of the communication, right? That we deal, that patients have to deal with. So make sure that they're routed as streamlined as it can be, and and it's not too hard for them to get to a person, a real person, if they need to ask questions and get the answer quickly, if at all possible. So hospitalization, we're looking at guidance to the field staff on how to manage high-risk patients, because we know there are a certain amount of these patients who are most likely to end up back in the hospital. How do we manage that? Visit utilization is appropriate for the patient's needs. So we are all looking at ways to be cost efficient these days, but we need to look at the patient's needs and not just have a cookie cutter approach to taking care of the patient. Some patients with heart failure might need a lower number because they've been at it for a while. Some patients with heart failure may need a lot more visits and a lot more visit utilization, just simply because they're brand new at it. They haven't had it very long, have a lot more questions, aren't managing it very well. Maybe their health literacy is not where it should be. or could be. So, all of those things, which is why OASIS-E looks at all those social determinants of health to make sure that we are meeting the patient's needs, but doing it as efficiently as we possibly can. Consistent communication with your field staff from the clinical manager, and that care coordination among all team members, talking to each other. I cannot stress it enough how important that is, so that we're all on the same page about a patient, about what that patient's needs are, and then what can be done for them. It will help move the needle. We may need to front load visits or stagger visits depending on what the patient's needs are. It still goes back to that. May want to use telehealth or remote patient monitoring for those high-risk patients to help supplement on-site or in-home visits for them. Collaborate with the physicians to get the patient evaluated in their office if we need to, instead of sending them back to the hospital. Let's try to get them in to see somebody at their doctor's office. That makes a whole lot more sense than sending them back to the emergency room or the hospital. So the quality team looks at all these trends, what's going on with it, conduct audits on all the patients that went back into the hospital. What happened? Why did this person end up back in the hospital? Were there abnormal symptoms present earlier on that we could have caught or stopped? Again, telehealth sometimes can, a lot of times if it's used appropriately, can help you recognize those things. Did we follow up with the patient, those hospitalized patients, once they're home, following up with them, and then making sure that that hospitalization risk assessment that we do is accurate at the start of care, and using it, working it into our care plans, making sure that we're doing appropriately there. So we've got actually a lot of suggestions for you on the OASIS. I'm running just a little short of time, but because I wanted to leave some time for Q&As. But the bottom line here is making sure that that we, from the very beginning, we have a discharge plan, whether or not is the patient progressing towards their goals or not, and do we need to add in any other disciplines, or is there a discipline that's in there that's really not helping us get better outcomes? We need to know all of those things. We need to look at it. We need to look at it in depth, and then figure out where, the best plan to go from there. So looking at the patient's status prior to discharge. So did we meet their goals? I mean, we don't just give them 7 visits and then at the end of 7 visits we go. We need to be evaluating the patient continuously and seeing if we've met their goals or not. If we meet them early, fantastic. Maybe maybe we could have done what we needed to do in 5 or 6 visits instead of 7 or 8. That's great. But if we also, on the other end of it, if we need to add another visit or 2, then let's figure that out before we discharge them. They get out, they go to end up back in the hospital. That's what we don't want to happen, right? So we need accurate OASIS information. And if the patient hasn't improved, then why? Looking at the discharge after they're gone, if the patient didn't improve, comparing it to scores from before, why didn't they improve? Could we have done anything differently? The field staff need to look at everything there is about the patient, their ability, their physical and cognitive. We can teach all day long, but if the patient doesn't understand it, either from a cognitive perspective or a health literacy perspective, we're not going to move that needle. We have to have the patient perform the task, at least walk us through it every time, or we will not get OASIS, an accurate OASIS answer. So we really have to do that. Okay. Looking at medical restrictions as well as caregiver availability on it as well. The OASIS is a very complex tool. And if you haven't done full OASIS training recently, maybe not with just OASIS-E, but all of it across the board, from soup to nuts, everything that factors into PDGM, everything that factors into value-based purchasing, not just the new E items, but the ones, these, what I refer to as the old ones that have been impacting our payment for a good while now and our outcomes. Then you need to have some OASIS training again, maybe a more comprehensive view of it, because it's a lot to know what's included or excluded in each of the OASIS items. Multitask items, meaning that we give more weight to some tasks that are more frequently performed, that only applies to certain questions or certain items. So we need to make sure that everybody understands how all of that works. Your quality team certainly has an impact on the OASIS, reviewing them. A lot of education that goes into it, making sure that your agency's up to date on the Q&As that are released quarterly. Clinical managers have a big role in the perception of our surveys, right? So how does the patient perceive the care that we give to them, the information that we're given to them, et cetera? So review what happens when a patient calls the agency. We do sometimes when we're out doing assessments on agencies as consultants, we do what we call mystery calls, and we just call in and we act like we're a patient or a patient's family, and we try to get through and see how hard it would be for a patient to get the answer that they need or to get through to somebody to help them out. And you would be amazed at the things that we get here and are told. So keep those kinds of things in mind. Think about what it looks like. What's the view from the patient in dealing with your agency? And then certainly try to proactively resolve any issues that come up, any service lapses or problems that arise. Work on them promptly and sincerely, not just I'm really sorry that happened to you kind of speech, but sincerely helping that patient feel better about what happened or didn't happen, as the case were, and then try to make it better for them. Great customer service training. We refer to it as customer perception training, because customer service is what we give. Customer perception is the patient's view of it. So it's extremely important to keep actually both the sides of that coin going well. All right, lots of education, redesigning those processes, redesigning your educational offerings as needed to meet what you need to do here in value-based purchasing. So have the patient, ask the patient when they want to be called, when or how they want to be called to schedule visits. Make sure that, I always tell my staff, don't tell them you're coming at 10 a.m. Tell them you're coming in the morning. And that opens it up. If at all possible, it opens it up to them. You have a less chance to fail being there at exactly the right time, because if you tell somebody exactly 10 a.m., odds are you might not make that. Review all the visits that have occurred since the last visit. See if it's the first time seeing the patient, so that when you go to see the patient, you are knowledgeable about them, and they don't have to start over and tell their whole story again to the next new staff that's coming out. That consistency of field staff, actually, which is, I know, harder said than done these days. I certainly get that, but it has a lot to do with it, so that we don't frustrate the patient. And always talk to our patients in a language that's easy for them to understand. All right, and then we've got some more very valid information here for you. I will, again, for a little bit for the sake of time, not go through each one of them. But the one point I will make from this one is that when you are talking to them about medication and pain and those things that show up on the CAHPS surveys, make sure that you review it every visit. Make sure, especially with safety, make sure that you are pointing out to them that you are teaching them about safety, because you might just be talking about falls risk or preventing them from falling, and they don't equate that with the word safety. The survey comes and it's got, did they talk to you about safety as the question? And they don't even recognize really maybe that you did probably tons of safety teaching. But make sure that you work in those words, have your staff practice working in all of those words, so that when the survey comes, now again, you can't coach the patient, you can't tell them what to say, but you can let it trigger the words in their mind, so that what you did teach on, is most likely to come back with them. Always answer the phone with a smile. Get a callback number just in case, because we could get cut off. And then make sure that every handoff is an opportunity to manage each other up, right? So we're setting that next person up for success. All right, so when we're looking at the home health CAHPS, remember that agencies are permitted to let them know that they're going to get a survey. You can conduct quality improvement activities around it, and that includes asking patient and family members questions about their well-being and promoting it. But we cannot give them anything that is a survey-like question or use the CAHPS survey like response categories. We can't prompt them. We can't give them, obviously, any kind of incentives of any kind to answer the questions. All right, we can't really attempt to influence those. So just to summarize real quick for you, you need to review those PIPR reports, look for areas to identify things, engage all team members in developing and implementing improvement plans, or continuing to. I'm going to stay on the positive side and say that if you are doing really well, then how do you keep it that way, right? Keep that in mind as well. And scoring well on the value-based purchasing takes everybody on the team. So make sure that everybody understands how they impact the agency scores. Okay, so do we have any questions? I've seen a few pop up in the Q&A there. Andrew, if you want to give me any.
Yes, a ton of great information and a lot of good questions that we can kind of speed through here for the end of the webinar. So firstly, when will we get the increase or decrease in payment based on VBP? And is there anything we need to do to get it?
Okay, great questions, actually. So 2023 is our first performance year, and it will be compared to the baseline scores from 22. From their calculations, and they're looking at everything from in 24 for that first payment adjustment that we would see in 2025. And you don't have to do a thing for the second part of that question. They will automatically, everybody's automatically enrolled in it. Yeah, you're automatically enrolled in it, and they'll just notify you of what you get or don't get as far as those adjustments. Good question.
Okay, great. We got this question a couple times. So if you have a chronically ill patient who is transferred to hospice, obviously like those outcomes wouldn't be as good. Are those counted against you in VBP?
That again is another really good question, but because we do, right? We get those patients, especially the long-term chronic ill patients who kind of are what I refer to as our frequent flyers who come and go a lot, and who we expect to decline, right? But they aren't to the point where we keep them for a good while before they get to the point where they're hospice appropriate. So CMS recognizes that we have some of those patients who we wouldn't really expect to see an improvement in. Alzheimer's patients are a good example, and others. But anyway, those specific measures, such as the OASIS-based, the TNC scores and mobility and self-care that I talked about, they are excluded from the value-based purchasing calculations for that exact reason, because they do recognize that we have a patient population where improvement would not be expected.
Okay, another good question. What pay sources are included in home health VBP?
Okay. Claims-based measures, the ones, the hospital and the emergency department use, are for Medicare fee-for-service claims only. The OASIS-based measures and the survey-based measures are Medicare fee-for-service, Medicare Advantage, Medicaid fee-for-service, and the Medicaid managed care pieces, and that's it. So no private insurance, none of the other payers other than your Medicare and Medicaid, but with the Medicare Advantage pieces thrown in.
Okay, great. A few more here. Are the agency OASIS-based scores that show up on the measure performance report the risk-adjusted scores or the actual values?
Ah,
That one might be tough.
oh,
because-
sure. I love the stump the teacher ones. Thanks a lot.
Well, I think this one also
I
was
should know it. It's
live.
a mix of them, actually, if I'm not mistaken. So I'll be glad to get information out after this if you guys want, on which ones are risk adjusted and which ones aren't, on that
Yep.
one.
That sounds good. I think that one was also live earlier on in the conversation, so it could have been more topical based on what you were saying at that point. So, okay. I guess Lynn asks, so I guess the bottom line is we need to try to be at least above that threshold.
Above the 50th percentile, ideally, to begin with, to get into the achievement scores, right? So that's what you're shooting for, again, minimally. But if not, that's where improving in each one of these measures is your next goal.
Yep,
So
absolutely.
achievement, were you at the 50th percentile, or improvement?
Another good question. Is HHVBP replacing the annual market basket increase, or is this in addition to?
This is different,
Yep, in addition
totally
to.
different.
Okay, great. All right, I think that's all we have. Claudia, is there anything else that you want to add that you may have not gotten to? We have just a few minutes left.
Yeah, no, I mean, unless anything else is on there, I just highly recommend that you guys implement all of the things that the actions and the to-do items that we had there at the end. We recognize as consultants what it's like out in the field with everybody. And it's tough because we've got so many other things and competing challenges going on. So we and any, not just us here at SimiTree, but in any number of other outside resources for you guys. If you need help with it, reach out now. I mean, now's the time to really be acting on these things. So ask for help if you need it, even if it's something small, short, or it could be a full assessment of how can I get better at all these things, because I'm really afraid, right? Because it is scary stuff. But we're out here to help anytime with anything you guys need. And I appreciate your time today.
Yep, thank you again to the audience for both listening in and engaging during the webinar. If you do have additional questions, feel free to reach out to SimiTree. And then also, Claudia, thank you so much for your time and insight. I think it was a very informative webinar, so I appreciate it.
All right, thank you. Everybody
Thank
have a
you.
good
Have a
day.
good one, everyone.